At what age should a child be able to walk independently, and what are the key developmental milestones observed between the ages of 1 and 3 years? Discuss the importance of these milestones in the context of pediatric care. Answer: a child typically walks independently around 12 months of age. Key developmental milestones between 1 and 3 years include 1 year, walks with assistance and may take a few steps independently, begins to say simple words e.g. mama, dada, follow simple directions. 15 months, walks alone well and begins to climb furniture, can say several single words, points to objects. 2 years, runs, kicks a ball and begins to climb stairs with assistance, speaks in two-word phrases e.g. more juice, can follow simple commands and is able to point to body parts. 3 years, can walk up and down stairs independently, speaks in three-word sentences and can be understood by strangers, engages in parallel play with peers. The American Academy of Pediatrics emphasizes that monitoring these milestones is crucial for early identification of developmental delays, allowing for timely interventions. Pediatricians should routinely assess these milestones during well-child visits to ensure appropriate growth and development. Describe the recommended immunization schedule for children from birth to 18 years of age. Why is adherence to this schedule critical in public health? Answer: the recommended immunization schedule includes the following key vaccines: at birth, hepatitis B, first dose, 2 months, DTaP, diphtheria, tetanus, pertussis, Haemophilus influenzae type B, HPV, inactivated polio vaccine, PCV, pneumococcal conjugate vaccine, RV, rotavirus vaccine, 4 months, DTaP, Hib IPV PCV RV second doses 6 months, DTaP, Hib IPV PCV RV third doses, and hepatitis B second dose 1 to 1 months, MMR, measles, mumps, rubella, varicella, chickenpox, Hib PCV fourth dose 18 months, DTaP fourth dose 4-6 years, DTaP fifth dose IPV fourth dose MMR second dose varicella second dose 1-2 years, Tdap tetanus, diphtheria, pertussis, HPV, human papillomavirus, MCV, meningococcal conjugate vaccine, 16 years. MCV booster adherence to the vaccination schedule is critical in preventing outbreaks of vaccine-preventable diseases, maintaining herd immunity, and protecting vulnerable populations who may not be able to receive vaccinations due to medical reasons. The CDC's immunization guidelines emphasize the role of vaccines in reducing morbidity and mortality from infectious diseases. Mr. Thompson brings his 4-year-old son to the clinic with a rash and fever. After examination, you suspect hand-foot-mouth disease (HMD). Describe the clinical presentation of HFMD and the management strategies you would recommend. Answer: hand-foot-mouth disease (HME) is a common viral infection, primarily caused by Coxsackie virus, characterized by the following clinical presentation. Symptoms: fever, often low-grade, sore throat, painful sores in the mouth, rash on the hands and feet, may also appear on the buttocks and legs. Clinical findings: oral ulcers can be seen, which may be painful and can interfere with eating and drinking. Vesicular rash on the palms and soles, which can progress to ulcers. Management strategies: symptomatic relief. Encourage fluid intake to prevent dehydration. Use acetaminophen or ibuprofen for fever and pain relief. Avoid acidic foods that may irritate oral sores. Hygiene measures: advise the family on good hand hygiene practices to prevent the spread of the virus. Instruct them to clean contaminated surfaces regularly. Isolation recommendations: advise the parents to keep their child home from school or daycare until fever-free and the mouth sores have healed. HFMD is usually self-limiting and no specific antiviral treatment is required. The CDC recommends monitoring for any complications, although they are rare. Discuss the approach to diagnosing secondary dysmenorrhea in a patient with chronic pelvic pain. What are the potential underlying conditions to consider and how should they be investigated? Answer: secondary dysmenorrhea refers to pain during menstruation that is caused by an underlying condition. The approach to diagnosing this involves detailed history, evaluate the character, location, and duration of the pain, assess associated symptoms such as heavy menstrual bleeding, dyspareunia, or bowel and bladder symptoms, review the patient's menstrual history, sexual history, and previous gynecological surgeries. Physical examination: perform a pelvic examination to assess for tenderness, masses, or abnormalities. Laboratory tests: complete blood count (CBC) to check for anemia. Pregnancy test to rule out pregnancy-related issues. Imaging studies: ultrasound to evaluate for conditions such as endometriosis, ovarian cysts, or uterine abnormalities. Possible underlying conditions to consider: endometriosis, uterine fibroids, adenomyosis, pelvic inflammatory disease (PID), ovarian cysts. Once a diagnosis is established, management may include medical treatment, hormonal therapies, NSAIDs, surgical intervention for severe cases, or referral to a specialist for further evaluation. What screening tools are available for assessing ADHD in children, and what considerations should be made regarding diagnosis and management? Answer: several validated screening tools are available for assessing ADHD in children, including Conners 3rd edition, Conners 3, a comprehensive tool that includes parent, teacher, and self-report forms to evaluate symptoms of ADHD and related behavioral issues. Vanderbilt ADHD Diagnostic Parent Rating Scale. This tool assesses symptoms of ADHD and also screens for coexisting conditions such as oppositional defiant disorder, odd and conduct disorder, CD. ADHD rating scale, a tool based on DSM-5 criteria to assess ADHD symptoms. Considerations for diagnosis: multifaceted approach. Diagnosis should involve gathering information from multiple sources, including parents, teachers, and other caregivers. Observational reports are essential to distinguish ADHD from other behavioral disorders. Age-appropriate criteria. The diagnosis must consider age-appropriate expectations for behavior, as symptoms may manifest differently in younger children compared to adolescents. Management strategies. Behavioral interventions. These include parent training in behavior management techniques and classroom strategies to enhance structure and minimize distractions. Pharmacological treatments. Stimulants e.g. methylphenidate and amphetamines are first-line medications. Non-stimulant options like atomoxetine may be considered for patients who cannot tolerate stimulants or have comorbid conditions. Follow-up and monitoring. Regular follow-ups are essential to evaluate treatment efficacy and make adjustments as needed. Explain the management of a patient diagnosed with gestational diabetes mellitus (GDM). What are the risks associated with untreated GDM for both the mother and the fetus? Answer: management of gestational diabetes mellitus (GDM) involves a multifaceted approach. Nutritional counseling. Provide individualized dietary education focusing on balanced meals with controlled carbohydrate intake to maintain blood glucose levels within target ranges. Physical activity. Encourage regular, moderate exercise e.g. walking to help regulate blood glucose levels. Monitoring. Regular self-monitoring of blood glucose levels, typically 4 times daily, fasting and postprandial medication. If dietary modifications and exercise are insufficient to control blood glucose levels, insulin therapy may be initiated. In some cases, oral hypoglycemic agents like metformin may be considered, although insulin is the preferred option during pregnancy. Fetal monitoring. Regular ultrasounds to assess fetal growth and well-being, particularly in the 3rd trimester. Risks of untreated GDM. For the mother, increased risk of developing preeclampsia, cesarean delivery, and future type 2 diabetes. For the fetus, high risk of macrosomia, large birth weight, neonatal hypoglycemia, respiratory distress syndrome, and increased risk of obesity and type 2 diabetes later in life. The American College of Obstetricians and Gynecologists (ACOG) recommends screening for GDM at 2-4 to 8 weeks of gestation, emphasizing the importance of early detection and management to mitigate these risks. How would you approach the diagnosis and management of a patient presenting with symptoms suggestive of chlamydia? What screening guidelines exist for this infection? Answer: the approach to diagnosing chlamydia includes patient history. Obtain a detailed sexual history, including recent partners and any history of styes. Symptom assessment. Common symptoms include abnormal vaginal discharge, burning sensation during urination, and lower abdominal pain. However, many cases can be asymptomatic. Laboratory testing. Nucleic acid amplification tests, not the preferred method for diagnosis due to their high sensitivity and specificity. Testing can be performed on urine or cervical swabs. Management. First-line treatment typically includes azithromycin 1 gram orally, a single dose, or doxycycline 100 mg twice daily for 7 days. Partner notification. Encourage patients to inform their sexual partners so that they can be tested and treated as necessary. Screening guidelines. The Centers for Disease Control and Prevention (CDC) recommends annual chlamydia screening for sexually active women under 25 and for older women with risk factors such as new or multiple partners. What are the key components of preconception counseling for women planning to conceive? Discuss the importance of addressing medical conditions and lifestyle factors. Answer: key components of preconception counseling include medical history review. Assess pre-existing medical conditions Diabetes, hypertension, thyroid disorders, and their management to optimize maternal health before conception. Medication assessment. Review current medications for safety during pregnancy and make necessary adjustments. Switching from teratogenic drugs to safer alternatives. Nutritional counseling. Emphasize the importance of a balanced diet rich in folic acid, 400 mg daily, to reduce the risk of neural tube defects, along with other essential vitamins and minerals. Lifestyle modifications address lifestyle factors such as smoking cessation, alcohol use reduction, and maintaining a healthy weight. Screening for STIs. Recommend screening for STs and provide education on safe sexual practices. Genetic counseling. Offer genetic counseling for women with a family history of genetic disorders or those at higher risk due to ethnic background. The importance of addressing these factors lies in optimizing maternal health, reducing the risk of pregnancy complications, and improving fetal outcomes. EU-S. Preventive Services Task Force USP recommends preconception cares, a critical component of family planning. What factors should be considered when recommending hormone replacement therapy (HRT) for a patient experiencing menopausal symptoms? Discuss the potential benefits and risks associated with HRT. Answer: when considering HRT for menopausal symptoms, the following factors should be evaluated. Severity of symptoms. Assess the impact of symptoms e.g. hot flashes, night sweats, vaginal dryness on the patient's quality of life. Medical history. Review the patient's history of hormone-sensitive cancers e.g. breast cancer, cardiovascular disease, thromboembolic events, and liver disease, as these may contraindicate HRT. Age and time since menopause. Initiating HRT in women under 60 or within 10 years of menopause may offer more benefits with fewer risks compared to older women. Type of HRT. Discuss options for combined HRT, estrogen and progestin for women with an intact uterus to reduce the risk of endometrial hyperplasia versus estrogen-only therapy for women post-hysterectomy. Potential benefits: relief from menopausal symptoms, improved bone density and reduced risk of osteoporosis-related fractures. Potential benefits in cardiovascular health when initiated early. Potential risks: increased risk of breast cancer, thromboembolic events, and stroke. Possible cardiovascular risks, particularly in older women or those with existing risk factors. The North American Menopause Society recommends individualized HRT decisions based on patient preferences, health status, and the risk-benefit analysis. What are the signs that may indicate child abuse, and what steps should a healthcare provider take if abuse is suspected? Answer: signs that may indicate child abuse include physical signs, unexplained bruises, burns, fractures, or other injuries that are inconsistent with the child's explanation or developmental stage. Behavioral signs: sudden changes in behavior, extreme withdrawal, fear of going home, or aggressive behavior. Developmental delays, failure to meet developmental milestones or regression in previously acquired skills. Neglect indicators: poor hygiene, malnutrition, inadequate supervision, or unsafe living conditions. Steps for healthcare providers: document findings. Carefully document any physical findings, behaviors, and the context in which they were observed. Conduct a sensitive assessment. Ask open-ended questions in a private setting to allow the child to express their feelings without leading or suggesting answers. Mandatory reporting. Understand that healthcare providers are mandated reporters in most jurisdictions, meaning they are legally required to report suspected abuse to Child Protective Services or appropriate authorities. Referral for support services. Consider referring the family to social services or counseling to provide support and ensure the child's safety. The Child Abuse Prevention and Treatment Act (CAPTA) mandates reporting requirements for suspected child abuse and emphasizes the role of healthcare providers in protecting vulnerable children. 45-year-old female patient presents with persistent sadness, lack of interest in activities she once enjoyed, and difficulty concentrating over the past 2 months. What screening tools could the physician use to assess her condition, and what treatment modalities should be considered based on the current guidelines? Answer: for this patient, effective screening tools include Patient Health Questionnaire 9P8Q9. This is a widely used instrument that assesses the severity of depression based on the presence of 9 depressive symptoms over the past 2 weeks. Beck Depression Inventory (BDA), another validated questionnaire that assesses the intensity of depression. Treatment modalities. According to the American Psychiatric Association (APA) guidelines for the treatment of major depressive disorder (MDD), the following options should be considered. Pharmacotherapy. Selective serotonin reuptake inhibitors (SRIs), such as sertraline or escitalopram, are typically first-line agents due to their efficacy and favorable side effect profile. Psychotropic medication monitoring. It's essential to monitor for side effects like nausea, sexual dysfunction, and insomnia, and to reassess the medication's effectiveness within 4-6 weeks. Psychotherapy, cognitive behavioral therapy (CBT). This is a structured, time-limited therapy focusing on changing negative thought patterns and behaviors associated with depression. Combination therapy. For moderate to severe cases, combining medications with psychotherapy has shown better outcomes than either treatment alone. Lifestyle modifications. Encouraging physical activity, proper nutrition, and sleep hygiene can complement treatment. Follow-up. Regular follow-up visits should be scheduled to monitor the patient's progress, adherence to treatment, and any side effects. Discuss the diagnostic approach and management for a patient suspected of having community-acquired pneumonia. CAP includes specific guidelines that should be followed. Answer. Diagnostic approach. History and physical examination. Assess symptoms such as cough, fever, dyspnea, and pleuritic chest pain. Check for signs of pneumonia, e.g., decreased breath sounds, crackles, dullness to percussion. Chest X-ray. A frontal chest X-ray is crucial to confirm the diagnosis and evaluate the extent of the pneumonia. It can show infiltrates which are indicative of pneumonia. Severity assessment. Use the Pneumonia Severity Index (PSI) or CUB-65 score to stratify the severity of the pneumonia and determine the appropriate treatment setting, outpatient versus inpatient. Management guidelines. According to the Infectious Diseases Society of America (ITSA) and the American Thoracic Society, its management should include outpatient treatment. For patients with low-risk features, recommended antibiotics may include macrolides, e.g., azithromycin or doxycycline. Inpatient treatment. For moderate to severe cases or patients with significant comorbidities, a beta-lactam, e.g., ceftriaxone, plus a macrolide or a fluoroquinolone, e.g., levofloxacin monotherapy may be required. Follow-up care. Reassess the patient within 4-8-72 hours to evaluate clinical response to treatment. Consider hospitalization if there's no improvement or worsening of symptoms. Mr. Thompson, a 38-year-old male, presents to the clinic after being encouraged by his family to seek help for his alcohol use. He reports drinking approximately 1-2 beers daily and has experienced withdrawal symptoms such as tremors and anxiety when he attempts to reduce his intake. What steps should the physician take to assess and manage Mr. Thompson's condition? Answer. Assessment steps. Comprehensive evaluation. Utilize the Alcohol Use Disorders Identification Test audit to assess the severity of Mr. Thompson's alcohol use. Gather a detailed medical history, including any past treatment for substance use, family history of addiction, and social supports. Physical examination. Assess for signs of alcohol dependence, withdrawal symptoms, e.g., tremors, sweating, and potential complications such as liver disease, e.g., jaundice, hepatomegaly. Withdrawal assessment. Use the Clinical Institute Withdrawal Assessment for Alcohol (CWA) scale to quantify withdrawal severity. Management steps. Medical stabilization. If Mr. Thompson is experiencing withdrawal symptoms, initiate treatment with benzodiazepines, e.g., lorazepam, to safely manage withdrawal and prevent complications like delirium tremens. Pharmacotherapy. After stabilization, consider long-term treatment options such as naltrexone reduces cravings and the reinforcing effects of alcohol. Acamprosate helps maintain abstinence in individuals who have stopped drinking. Psychosocial interventions. Refer Mr. Thompson to counseling or support groups, e.g., Alcoholics Anonymous, to provide a support network and assist with long-term recovery strategies, monitoring and follow-up. Schedule regular follow-up appointments to monitor his progress, address any emerging issues, and ensure adherence to the treatment plan. In the management of a patient with chronic low back pain, what are the recommended non-pharmacological strategies? Please elaborate on the evidence supporting these strategies according to clinical guidelines. Answer. Recommended non-pharmacological strategies. Physical therapy. Tailored exercise programs led by physical therapists can improve functional outcomes and reduce pain. Evidence. Studies have shown that patients participating in physical therapy experience significant improvement in pain and disability levels. Exercise. Regular physical activity, including aerobic exercises, walking, swimming, and strength training, is encouraged. Evidence. The ACP guidelines recommend exercise as an effective treatment for chronic low back pain. Cognitive behavioral therapy (CBT). CBT helps patients manage pain by changing negative thought patterns and improving coping strategies. Evidence. Research indicates that CBT can lead to improved pain management and mental well-being in patients with chronic pain. Multidisciplinary rehabilitation. Programs integrating physical therapy, psychological support, and occupational therapy are beneficial. Evidence. These programs have shown efficacy in improving quality of life and reducing pain. Acupuncture and massage therapy may provide symptomatic relief for some patients, although more research is needed for strong recommendations. Follow-up. Regular follow-up should assess the patient's response to these interventions and adjust the treatment plan accordingly. A 19-year-old female presents with significant weight loss, amenorrhea, and a preoccupation with body image. What criteria should be used for diagnosing anorexia nervosa, and what initial management steps should be taken? Answer. Diagnostic criteria: DSM-5, restriction of energy intake, significantly low body weight in the context of age, sex, developmental trajectory, and physical health, intense fear of gaining weight, persistent behavior that interferes with weight gain even when underweight, distorted body image, a distorted self-evaluation of body weight or shape, or an undue influence of body weight or shape on self-worth. Initial management steps: medical stabilization, assess and monitor vital signs, electrolytes, and overall health status. Hospitalization may be required for severely underweight patients, BMI 15. Nutritional rehabilitation. Develop a structured refeeding program with a registered dietitian to gradually restore body weight. Monitor for refeeding syndrome, particularly if rapid refeeding occurs. Psychiatric evaluation. Engage mental health professionals for psychotherapy. Cognitive behavioral therapy (CBT) is considered effective for treating anorexia. Family involvement. Include family in treatment planning, as family dynamics can significantly impact recovery. Education and support. Educate the patient and family about anorexia nervosa, emphasizing the importance of treatment and the risks of the disorder. What are the key factors in conducting a skin cancer screening examination, and what recommendations are outlined by the American Academy of Dermatology for high-risk individuals? Answer. Key factors for screening: patient history, document the patient's skin type, history of sun exposure, previous skin cancers, and family history of skin cancer. Physical examination. Conduct a thorough head-to-toe skin examination, paying close attention to moles, pigmented lesions, and areas of sun exposure. ABCD criteria for melanoma detection: asymmetry, one half of the mole doesn't match the other; border, irregular, scalloped, or poorly defined edges; color varied from one area to another, shades of tan, brown, black, or sometimes red, white, or blue; diameter larger than 6 millimeters; the size of a pencil eraser; evolving changes in size, shape, color, or elevation, or new symptoms such as bleeding, itching, or crusting. Recommendations for high-risk individuals: regular skin examinations. Patients with a history of skin cancer or high-risk factors, e.g. fair skin, history of severe sunburns, should have regular skin examinations by a dermatologist, typically every 1–2 months. Self-examinations. Encourage monthly self-skin exams to identify new or changing lesions. Sun protection measures. Use broad-spectrum sunscreen SPF 30 or higher daily. Wear protective clothing and avoid tanning beds. Education. Provide education about the importance of early detection and the signs of skin cancer. Discuss the role of lifestyle modifications in managing hypertension and outline the pharmacological treatment options as recommended by the latest clinical guidelines. Answer. Lifestyle modifications. Dietary changes. DASH diet emphasizes fruits, vegetables, whole grains, and low-fat dairy while reducing saturated fat and cholesterol. Sodium reduction. Limit sodium intake to 2300 mg/day and ideally 1500 mg/day for significant blood pressure reduction. Physical activity. Encourage at least 150 minutes of moderate intensity aerobic exercise per week. Weight management. A weight loss of 5–10% can significantly lower blood pressure. Alcohol moderation. Limit alcohol consumption to no more than 1 drink per day for women and 2 drinks per day for men. Stress reduction. Techniques such as mindfulness, meditation, or yoga can help manage stress levels. Pharmacological treatment options. According to the 2021 ACAHA hypertension guidelines, initial pharmacotherapy may include thiazide diuretics, such as hydrochlorothiazide, particularly effective in older adults; ACE inhibitors, such as lisinopril, indicated especially in patients with comorbid conditions like diabetes or heart failure; angiotensin I receptor blockers, ARBs, such as losartan, are often used as an alternative to ACE inhibitors; calcium channel blockers, such as amlodipine, are beneficial in certain populations, including older adults and those with isolated systolic hypertension; beta blockers, reserved for patients with specific indications such as heart failure or a history of myocardial infarction. Follow-up. Regular monitoring of blood pressure and side effects is crucial, with adjustments made based on treatment response. In the case of a patient presenting with signs of an acute ischemic stroke, what are the immediate diagnostic and management steps that should be taken according to current guidelines? Answer: immediate diagnostic steps. Rapid assessment. Use the FAST face, arms, speech, time mnemonic for quick evaluation of stroke symptoms. Emergency imaging. Perform a non-contrast CT scan of the head within 25 minutes of arrival to rule out hemorrhagic stroke and assess for ischemic changes. Laboratory tests. Obtain basic lab tests including blood glucose electrolytes and coagulation profiles. Management steps. Thrombolysis. If the patient presents within 4.5 hours of symptom onset and has no contraindications, administer intravenous tissue plasminogen activator (EPA) thrombectomy. Consider mechanical thrombectomy for patients with large vessel occlusions within 6 to 4 hours of symptom onset if they meet specific criteria. Secondary prevention. After stabilization, initiate secondary prevention strategies including antiplatelet therapy, aspirin, and statin therapy to manage risk factors. Neurological assessment. Monitor neurological status and assess functional capacity using standardized scales, e.g. NIS. Outline the approach for managing a patient diagnosed with type 2 diabetes mellitus, focusing on lifestyle interventions and pharmacotherapy based on the latest ADA standards. Answer: lifestyle interventions. Dietary modifications. Encourage a well-balanced diet that focuses on whole grains, fruits, vegetables, lean proteins, and healthy fats. Limit simple carbohydrates and processed sugars. Physical activity. Aim for at least 150 minutes of moderate intensity aerobic exercise per week. Weight management. Achieve a weight loss of 5% of body weight to improve glycemic control. Self-monitoring of blood glucose. Educate patients on monitoring their blood glucose levels to inform dietary and medication adjustments. Pharmacotherapy. According to the American Diabetes Association (ADA) standards of medical care in diabetes, the following treatment options are available. Metformin. This is the first-line pharmacological therapy due to its efficacy, safety profile, and weight neutrality. Additional medications. If additional glycemic control is needed, consider GLP-1 receptor agonists, e.g. liraglutide, for weight loss benefits, ALT inhibitors, e.g. empagliflozin, to reduce cardiovascular risk and renal protection. Insulin therapy may be necessary if blood glucose levels remain uncontrolled. Monitoring and follow-up. Regular follow-up should be conducted to assess treatment effectiveness, adjust medications, and screen for complications. Describe the diagnostic workup for a patient suspected of having hypothyroidism and outline the management strategies based on the latest clinical guidelines. Answer: diagnostic workup. Clinical history and symptoms. Evaluate for symptoms such as weight loss, palpitations, heat intolerance, and tremors. Physical examination. Assess for signs like goiter, tremors, and hyperreflexia. Laboratory tests. Obtain TSH and free levels. In hypothyroidism, TSH is low and free T is elevated. Thyroid antibodies. Check for antibodies such as TSH receptor antibodies to confirm Graves' disease. Radioactive iodine uptake (RAU). A thyroid scan can help differentiate between causes of hypothyroidism, e.g. Graves' disease versus toxic nodular goiter. Management strategies. Antithyroid medications. Methimazole or propylthiouracil, PA2, are first-line treatments that inhibit thyroid hormone synthesis. Beta blockers, used to manage symptomatic relief of palpitations and tremors. Radioactive iodine therapy, considered for patients who are not in remission after antithyroid medications or have moderate to severe disease. Surgery. Thyroidectomy may be indicated in cases of large goiters, suspicion of malignancy, or if the patient prefers this option. Regular monitoring. Regularly monitor thyroid function tests to assess treatment efficacy and adjust medications as necessary. Each response is tailored to encompass critical aspects of diagnosis and management in line with current clinical guidelines and practices. In managing a patient with stage 1 hypertension, what considerations should be taken into account regarding lifestyle modifications and pharmacological treatment according to current guidelines? Answer: management of stage 1 hypertension, systolic BP 130-139 mm Hg or diastolic BP 80-89 mm Hg begins with assessing the patient's overall cardiovascular risk. Lifestyle modifications are essential and include dietary changes. Encourage adherence to the DASH dietary approaches to stop hypertension. Diet which emphasizes fruits, vegetables, whole grains, and low-fat dairy while reducing saturated fats and cholesterol. Physical activity. Patients should be encouraged to engage in regular physical activity, ideally 150 minutes of moderate intensity exercise weekly. Weight management. For overweight individuals, a 5-10% reduction in body weight can significantly lower BP. Alcohol limitation. Advise reducing alcohol intake to no more than 2 drinks per day for men and 1 for women. Smoking cessation. Strongly recommend quitting smoking as it significantly increases cardiovascular risk. Pharmacological treatment. If lifestyle changes alone are insufficient, the use of antihypertensive medications should be considered, especially in patients with comorbidities such as diabetes or chronic kidney disease. The choice of medication may include thiazide diuretics (ACE), inhibitors, angiotensin I receptor blockers, ARBs, calcium channel blockers. Guidelines. According to the American College of Cardiology (AC) and American Heart Association (AHA) guidelines, treatment initiation should occur when BP readings consistently exceed the thresholds mentioned, particularly in high-risk patients. Describe the key components of a comprehensive management plan for a patient diagnosed with COPD, including pharmacological and non-pharmacological interventions. Answer: a comprehensive management plan for chronic obstructive pulmonary disease (COPD) should incorporate both pharmacological and non-pharmacological strategies. Pharmacological interventions. Bronchodilators. Short-acting bronchodilators, SOBAs, for quick relief. G. Albuterol. Long-acting bronchodilators, LOBAs. G. Salmeterol, formoterol, for maintenance therapy. Inhaled corticosteroids, ICS, recommended for patients with a history of frequent exacerbations despite L8BA therapy. Combination inhalers. These combine L8B with ICS for enhanced management in moderate to severe COPD. Phosphodiesterase 4 inhibitors, such as roflumilast, for patients with chronic bronchitis and a history of exacerbations. Oxygen therapy. For patients with hypoxemia, maintaining oxygen saturation above 90% can improve outcomes. Non-pharmacological interventions. Smoking cessation. The most crucial intervention to provide resources and counseling. Pulmonary rehabilitation. Engaging patients in a structured program can improve quality of life and physical function. Vaccination. Annual influenza and pneumococcal vaccinations to prevent respiratory infections. Nutritional support. Encourage a balanced diet to help maintain optimal body weight, considering weight loss can adversely affect respiratory function. Guidelines. The Global Initiative for Chronic Obstructive Lung Disease (GOLD) provides a detailed framework for the diagnosis, management, and prevention of COPD, emphasizing the importance of a tailored approach based on individual patient characteristics. Explain the importance of advanced directives in end-of-life care and the ethical considerations a family physician should address when discussing these directives with patients. Answer: advanced directives are critical tools in end-of-life care, allowing patients to express their preferences regarding medical treatment should they become unable to communicate these wishes. Key aspects include types of advanced directives. Living will outlines specific treatments the patient wishes to receive or avoid. Durable power of attorney for healthcare designates a surrogate decision-maker importance. Autonomy. Advanced directives respect the patient's autonomy by ensuring their healthcare decisions are honored. Clarity. They provide clarity for family members and healthcare providers, reducing conflict during emotionally charged times. Ethical considerations. Informed consent. Physicians should ensure that patients understand their options and the implications of their choices. Cultural sensitivity. Be aware of cultural differences that may affect patients' views on end-of-life care and discussions surrounding death. If a patient diagnosed with atrial fibrillation, what factors should be considered when determining the appropriate anticoagulation therapy? Answer: when managing a patient with atrial fibrillation (AF), several factors must be considered to determine the appropriate anticoagulation therapy. Stroke risk assessment. Use the CHANCE-VASc score to evaluate stroke risk. A score of 2 or higher typically indicates the need for anticoagulation. Bleeding risk. Assess the patient's bleeding risk using the HAS-BLED score. This includes evaluating factors such as hypertension, renal function, and previous bleeding history. Type of AF. Consider whether the AF is paroxysmal, persistent, or permanent, as this may influence management strategies. Patient preferences. Discuss the risks and benefits of anticoagulation options with the patient, including direct oral anticoagulants, DOACs versus warfarin. Kidney function. Assess renal function, as certain DOACs require dosage adjustments in patients with renal impairment. Concurrent medications. Evaluate any potential drug interactions that may affect anticoagulant therapy, particularly with other medications that influence coagulation. Mr. Thompson, a 68-year-old male with metastatic prostate cancer, presents with increasing pain despite being on a regimen of oral opioids. He expresses concern about becoming addicted and requests alternatives. How should you address Mr. Thompson's concerns and optimize his pain management plan? Answer: addressing Mr. Thompson's pain management requires a compassionate and comprehensive approach. Here's how to proceed. Assessment: conduct a thorough pain assessment to determine the nature, location, intensity, and duration of his pain. Evaluate the effectiveness of the current opioid regimen, including any side effects he may be experiencing. Education: discuss the difference between physical dependence, tolerance, and addiction. Explain that when used appropriately, opioids can be an effective component of pain management, especially in cancer patients. Multimodal approach: just opioid therapy. Consider increasing the opioid dosage or switching to a different opioid if Mr. Thompson is experiencing inadequate relief. Utilize the concept of equianalgesia to ensure safe transitions between different opioids. Non-opioid medications: introduce adjunctive medications such as NSAIDs, acetaminophen, or adjuvant analgesics like gabapentin or pregabalin for neuropathic pain. Non-pharmacological interventions: recommend physical therapy, acupuncture, or cognitive behavioral therapy as adjuncts to pharmacological treatment. Palliative care consultation: engage a palliative care team to provide specialized support for symptom management and to address complex pain issues. Regular follow-up: schedule regular follow-ups to reassess pain levels and the effectiveness of the adjusted pain management plan. This ongoing evaluation is crucial to adapt treatment as needed. Guidelines: the National Comprehensive Cancer Network (SEN) provides guidelines for pain management in cancer patients, emphasizing a holistic approach that considers both pharmacologic and non-pharmacologic strategies. Discuss the recommended approach for managing a patient diagnosed with community-acquired pneumonia (CAP), including diagnostic criteria, treatment guidelines, and considerations for hospitalization. Answer: the management of community-acquired pneumonia (CAP) involves a systematic approach to diagnosis, treatment, and follow-up. Diagnostic criteria: CAP is diagnosed when a patient presents with acute respiratory symptoms, fever, and new infiltrates on chest imaging. Criteria for severity assessment include CUB-65 score, evaluates the need for hospitalization based on confusion, urea levels, respiratory rate, blood pressure, and age 65 years. Empirical treatment: for outpatient treatment, consider first-line antibiotics such as macrolides e.g. azithromycin or doxycycline. For patients with comorbidities or recent antibiotic use, beta-lactam antibiotics e.g. amoxicillin clavulanate combined with a macrolide or a respiratory fluoroquinolone e.g. levofloxacin. Hospitalization criteria: hospitalization may be necessary for patients with severe CAP as indicated by a CUB-65 score of 2 or higher, need for intravenous antibiotics, fluid management, or monitoring due to complications e.g. pleural effusion. Follow-up: patients should be reassessed within 4-8-72 hours to evaluate treatment response and adjust the plan as necessary. Consideration for follow-up chest imaging may be warranted if symptoms persist. Guidelines: the Infectious Diseases Society of America (ITA) and the American Thoracic Society provide detailed guidelines on the diagnosis and management of CAP, emphasizing evidence-based approaches. Explain the approach to treating hyperlipidemia in adults, including the use of statins and the importance of individualized treatment goals. Answer: the treatment of hyperlipidemia involves a multifaceted approach centered around lifestyle modifications and pharmacotherapy, particularly the use of statins. Lifestyle modifications: patients should be encouraged to adopt heart-healthy habits, including dietary changes, increase intake of fruits, vegetables, whole grains, and omega-3 fatty acids while reducing saturated fats and trans fats. Physical activity: aim for at least 150 minutes of moderate intensity exercise per week. Weight management: achieving a healthy weight can significantly improve lipid profiles. Statin therapy: statins are first-line agents for managing hyperlipidemia. The decision to initiate statin therapy is based on ASCVD risk assessment. Use the American College of Cardiology American Heart Association (ACAHA) ASCVD risk calculator to guide treatment decisions. High-intensity statin therapy is recommended for individuals with a history of cardiovascular events or those with a calculated 10-year ASCVD risk of 20% or more. Moderate intensity statins, recommended for individuals age 40-75 with diabetes and LDL cholesterol level of 7018 nmol, as well as those without diabetes but with a 10-year ASCVD risk of 20% or more. Monitoring and follow-up. Regular follow-up appointments are crucial to monitor lipid levels, assess adherence, and adjust therapy as needed. Lipid panels should be checked for 1–2 weeks after initiating or adjusting statin therapy. Individualized treatment goals. Consider individual risk factors and patient preferences when determining LDL cholesterol targets and discussing potential side effects of therapy. Guidelines. The 2018 AHOG guidelines provide comprehensive recommendations for the treatment of blood cholesterol to reduce atherosclerotic cardiovascular disease risk. Describe the principles of asthma management in adults, focusing on both pharmacological treatment and non-pharmacological strategies. Answer. The management of asthma in adults should encompass both pharmacological and non-pharmacological strategies to achieve optimal control of symptoms and prevent exacerbations. Pharmacological treatment. Quick-relief medications. Short-acting beta-2 agonists. SUBs, such as albuterol, should be prescribed for acute symptom relief. Long-term control medications. Inhaled corticosteroids are the cornerstone of long-term asthma management. For patients with persistent asthma, a combination of ICS and long-acting beta-2 agonists (LOBAs) is recommended. Leukotriene modifiers, such as montelukast, can be considered for patients who have difficulty achieving control with ICS alone. Biologic therapies. For patients with severe asthma and a history of exacerbations, biologic therapies e.g. omalizumab, mepolizumab may be indicated. Non-pharmacological strategies. Patient education. Teaching patients about their condition, the proper use of inhalers, and the importance of adherence to medication regimens. The asthma action plans. Develop individualized action plans that outline daily management strategies and steps to take during exacerbations. Trigger identification. Encourage patients to identify and avoid environmental triggers such as allergens and irritants e.g. tobacco smoke, strong odors. Regular monitoring. Patients should regularly monitor their asthma symptoms and peak expiratory flow rates to detect worsening control. Guidelines. The Global Initiative for Asthma (GINA) provides comprehensive guidelines for the management of asthma, emphasizing a stepwise approach to therapy based on symptom control and exacerbation history. Outline the critical steps in the management of anaphylaxis, including the role of epinephrine and follow-up care. Answer. Anaphylaxis is a severe, life-threatening allergic reaction that requires immediate intervention. The critical steps in management include recognition of symptoms. Common symptoms of anaphylaxis include difficulty breathing, swelling of the face or throat, hives, abdominal pain, and a rapid drop in blood pressure. Immediate administration of epinephrine. First-line treatment. Administer intramuscular epinephrine 0.3–0.5 ng for adults, 0.1 mg for children. As soon as anaphylaxis is suspected, epinephrine can be repeated every 5 minutes if symptoms persist. Preferred site. The anterolateral thighs, the recommended injection site for optimal absorption. Supplemental oxygen and airway support. Provide supplemental oxygen and be prepared for advanced airway management if the patient exhibits respiratory distress. Intravenous fluids. Administer IV fluids for hypotension or signs of shock. Antihistamines and corticosteroids. While these can be administered after epinephrine, they should not delay or replace epinephrine administration. Monitoring. Patients should be monitored in a medical facility for at least 4–6 hours after the initial episode due to the risk of biphasic anaphylaxis. Follow-up care. Patients should be educated on avoiding triggers and prescribed an epinephrine auto-injector for emergency use. Referral to an allergist for further evaluation and management is recommended. Guidelines. The National Institute of Allergy and Infectious Diseases and the Food Allergy and Anaphylaxis Network provide detailed guidelines for the recognition and management of anaphylaxis, emphasizing prompt and effective treatment. Discuss the ethical considerations a family physician should navigate when providing care for terminally ill patients, particularly in relation to autonomy, beneficence, and non-maleficence. Answer. Ethical considerations in end-of-life care for terminally ill patients are complex and multifaceted, centering around the principles of autonomy, beneficence, and non-maleficence. Autonomy. Respecting patient autonomy is paramount. Physicians must ensure that patients are fully informed of their condition and treatment options, enabling them to make decisions consistent with their values and preferences. This includes discussions about advance directives and the right to refuse treatment. Beneficence. The principle of beneficence emphasizes acting in the best interest of the patient. Physicians should strive to provide care that enhances the patient's quality of life and alleviates suffering, which may include palliative care measures and symptom management. Non-maleficence. Non-maleficence requires that healthcare providers avoid causing harm. This can be particularly challenging in terminally ill patients where aggressive treatments may prolong suffering without a significant benefit. Physicians must balance the potential benefits and burdens of treatment options. Communication. Effective communication with patients and families about prognosis, treatment options, and potential outcomes is critical. This fosters shared decision-making and helps align treatment plans with the patient's goals. Cultural sensitivity. Be aware of cultural differences in perceptions of death, dying, and appropriate care. Engaging in culturally competent discussions can improve the therapeutic relationship and care outcomes. Interdisciplinary approach. Collaboration with palliative care teams, social workers, and ethics committees may be necessary to navigate complex ethical dilemmas in end-of-life care. Guidelines. The American Medical Association (AMA) provides ethical guidelines for end-of-life care, underscoring the importance of respect for patient autonomy and the obligation to alleviate suffering.